The second presenter for today is Dr. K.A.D.N.P. Samarathunga, who is a senior registrar in adult cardiology at National Hospital, Kandy. His topic is on overview of cardiomyopathies. Over to you, Dr. Samarathunga.
Thank you, Ceylon College of Physicians, for giving this opportunity. So my topic for today is overview of cardiomyopathies. So it's a vast topic. So outline of my talk will be I will go with classification, and I will talk about common type of cardiomyopathies like hypertrophic cardiomyopathy, dilated cardiomyopathy, and a variety of dilated cardiomyopathy, peripartum cardiomyopathy, restrictive cardiomyopathy, and diabetic cardiomyopathy as well. So because of time constraint, I will not talk about erythropoietic right ventricular cardiomyopathy and left ventricular non-conduction cardiomyopathy. Takotsubo cardiomyopathy is not a major type, but I will not also do. But my presentation will have all the slides. Because of the time constraint, some slides I will try to skip. So you can get the presentation from this link, and if there's a mark like this, so those slides I will not talk, but you can go through it when you have free time. And if you have any questions, you can just send it to me later. So I will try to answer each and every question. So what is the definition of cardiomyopathy? So it's a heart muscle disease. It's sufficient to cause and structural or functional cardiac abnormality. And usually it's the absence of coronary heart diseases, hypertension, valvular heart disease, or congenital heart disease. So I will skip this slide. There's a cardiomyopathy classification, but you can get the slides later. So there's a newer classification for this MOX classification. This M refers to the phenotype, O refers to the organ involvement with or without extracardiac involvement. G refers to the genetic transmission. E for pathogenesis, and S refers to the disease stage. So if this is a MOX classification, so you can see ideally this will have something like this. So this is a dilated cardiomyopathy, and it was atrioventricular bundle branch blockage also there. There's organ involvement is heart, and there's autosomal dominant, and this genetic cause is there. They cause fine genetic cause also, and the stage of the disease. So there are mainly five types of cardiomyopathy: conventionally, hypertrophic, dilated, restrictive, erythropoietic right ventricular, and left ventricular uncompaction. And there's some overlapping with this as well, because some genetic causes are found in both diseases. So moving to hypertrophic cardiomyopathy, which is the most prevalent one. Usually 1 in 500 patients are getting it, and its mutation is in sarcomere protein. So you can see this compared to the normal cardiac muscle. This hypertrophic cardiac muscle is there's a one side visceral, so it's not normal. So it's mainly has this hypertrophy and increased fibrosis and hypercontractility, and there's impaired relaxation, and there's altered myocardial energetics as well, including mitochondrial functions. So if you get the symptoms and signs, some patients can be asymptomatic, and they can have exertional shortness of breath, fatigue, syncope, pre-syncope, chest pain, palpitation. There may be hence family history of sudden cardiac death. And if you go to the examination, they can have prominent LVA apical impulse, S4, pansystolic murmur of mitral regurgitation, but they can have even systolic murmurs. And important thing is this murmur will increase with condition which increases the venous return, like valsalva and upright posture, reduces the increase venous return. So like if you increase the venous return, like sitting or squatting position or hand grip, which will reduce the murmur. So if you want to evaluate it, usually you should have after history and physical exam, and you take the family history, and you take the ECG, and echo is the mainstay of diagnosis, and ideally you need cardiac MRI for each and every patient. After that, you need the genetic testing. It usually not being done commonly in Sri Lanka. After the echo, you have to find it whether it's a resting obstruction, or there is if there's resting obstruction, there is obstructive cardiomyopathy. If there's no obstruction, you have to provocate it with various provocation tests. So if you find some ECG findings, they can have LVH criteria. They can have giant T inversions, mainly in apical cardiomyopathy. They can have septal Q waves. They can have left atrial enlargement and short PR and various types of arrhythmias. So in this ECG, you having some LVH criteria, and there is and you can some skew waves are also there in lateral leads, and you can see some biphasic inversions. You may suspect this is a valence, but this is not valence. So if you have to be the valence, patient has to be in acute, come with acute coronary syndrome, and they should be compatible. But in this patient, if you find it is like LVH patient, it's more likely due to LV strain rather than ischemic origin. So in this ECG, you can see this giant T waves, T inversions in the precordial leads. And this is typical hypertrophic cardiomyopathy. So if you get an echo, so you can see this interventricular septum is grossly enlarged. And in the systole, there is anterior motion of the mitral valve causing LV outflow tract obstruction. It's called the SAM. So if you had an echo finding of LV thickness more than 50 millimeters, you may think this is more likely hypertrophic cardiomyopathy. But 13 to 14 can be also diagnostic, especially if they have some family history or patient who has pediatric age group. So differential diagnosis, hypertension and as it starts. So in hypertrophic cardiomyopathy, there can be several phenotypes. Presentation can be present sudden cardiac death or near cardiac arrest. They can have obstructive cardiac failure. It's like non-obstructive heart disease, or they can develop atrial fibrillation and stroke. So important thing is in every hypertrophic cardiomyopathy patient should have an Holter done, because this, as I shown earlier, its cardiac muscle is not normal. So they can have various tachyarrhythmias, bradyarrhythmias, and including AF. So they might need anticoagulation. And important thing is you can calculate the risk with CAD-VASCO. Because it's not validated for hypertrophic cardiomyopathy. So if the patient knows, what they say is, if the patient is an LA diameter more than 50 millimeters, you should consider anticoagulant, even there is no demonstrable atrial fibrillation, because we do only short-term Holter monitoring. We don't should do long-term, like 6 months, 12 months Holter monitoring. So sudden cardiac risk assessment, you can do this. There are various calculators are there, ESC1 and EHC1 are there. As I told earlier, these slides I'm going to skip. So if there's a risk, like what are the risk patients, who are the risk patients, who are the previous VF, who has a spontaneous NSVT, the family sudden cardiac death, are major distractors. But if the patient has unexplained syncope, LV wall thickness more than 30 millimeters, and abnormal blood pressure with exercise, especially there's dropping of blood pressure with exercise, that's a high risk for sudden cardiac death. So if you take the sudden cardiac death completely at least, hypertrophic cardiomyopathy is the major cause. So if you take how are you going to manage this? So if, as I told earlier, sudden cardiac death patient might need ICD, and progressive obstructive heart disease, after trying medication like beta blockers or verapamil, you might have to go with alcohol septal ablation or surgical myomectomy. Progressive non-obstructive heart disease, the EF is low, you have to go standard heart failure medication. If there's AF, you can use anticoagulation or catheter ablation. So this is the main thing. Obstructive heart disease, if there's a resting obstruction, you can either try verapamil or beta blockers, but if there is with the obstruction with exercise, you can beta blocker is the first line of drug. And you also try disopyramide after failing these drugs. And the newer drug is this myosin inhibitor, mercaptan, which was found in proven in SCM trial. And other newer treatment like gene editing is also in the horizon. So these drugs should be ideally avoided, like these vasodilators, the various like GTNs, amlodipine, and AC inhibitor ARB. But mind, if the patient has heart failure, with reduced ejection fraction, you can still give AC inhibitor ARB with caution. So this is how we do with surgical myomectomy. You surgically remove that obstructive part, or we can do a percutaneously. We are alcohol septal ablation. We inject alcohol after occluding the proximal vessel with the balloon, so that it will not leak to the main vessel. So you create an artificial iatrogenic MI with the septal branch of the LAD. So there are newer drugs in the horizon too. Okay. So follow up is usually we do once a year, unless they is not complicated. So family screening usually should begin around 12 years, and after 12 months is 1 year to 3 months until about 21 years. Then you can do like 5-year intervals. Because there are some patients we can have this phenotypes. They can have this. They can have phenotypes. Genetic, they have genes. But there is no phenotype. It's not elicited. And so exercise. So if you what kind of type of exercise they can do. So if the patient is asymptomatic and there is no LV obstruction and there is blood pressure response to exercise is normal and there's no arrhythmia on Holter, you can have high intensity exercise with regular monitoring. But if the patient have high risk lot of symptoms, and if you can describe showing high risk of calculation and LVOT obstruction is great, and there's blood pressure drop with exercise, and there's exercise in this NSVT arrhythmias, they only can have moderate like aerobic type of exercise, not high intensity exercise. So let's move into dilated cardiomyopathy, which actually is non-ischemic heart muscle disease, which have left or biventricular dilatation with systolic dysfunction in the absence of coronary artery hypertension or valvular heart disease. So there is LV dilatation with resulting remodeling and fibrosis. So usually its cause is idiopathic. Up to 25% can be familial, mainly autosomal dominant, and sometimes X-linked, and sometimes infection can be the cause in about 30% of diseases. Rare causes like viral myocarditis, alcohol, toxins, and autoimmune diseases also play a part. So this is a type. There are a lot of types of dilated cardiomyopathy. Virtually any type of infections, inflammatory conditions, toxins, chemotherapy, pregnancy, peripartum can cause this dilated cardiomyopathy. So if you take the ECGs, they can have left atrial enlargement, biatrial enlargement, LVH criteria. Mainly, they can have left bundle branch block, and they can have pseudo-infarct pattern with QX complexes in precordial leads and various types of arrhythmias as well. So in this CC, you can see the LVH criteria, LV strain, and there's you can see this right atrial dilatation plus LA dilatation. So this CC is showing actually left bundle branch block pattern with atrial fibrillation. So if you take a 2D echocardiogram, you can see this LV is dilated. Usually, what we say is less than 58 in men and for the 52 in female as normal. But this is mainly not very good for Sri Lanka. Sri Lankan ideally you should have divided by the body surface area. And this LV is dilated, and there's a LV thrombi as well. And the patient usually have this functional mitral regurgitation due to annular dilatation. Cardiac MRI is very crucial, but usually we are not having facilities to in each and every patient. So if you suspect that the patient has symptoms of dilated cardiomyopathy after treating for heart failure, and if there's improvement, you just continue the treatment. But if there's no improvement, they should ideally have endomyocardial biopsy, because there can be persistent inflammation going on, persistent some infections going on, and which can be treated, have specific treatments. So we can do endomyocardial biopsy, subvenous approach, subclavian or femoral approach. We do have facilities to endomyocardial biopsy as well. And there are etiology-based treatments like antivirals, immunosuppressions, which have been proven in various trials as well. And there are regenerative medicine with stem cells transplantation as well. Okay, so this is very important. So as you know, this is a heart failure of reduced ejection fraction guideline. So dilated cardiomyopathy patient usually have heart failure with reduced ejection fraction. So mainstay of treatment will be ACE inhibitor, ARB or ARNI, and beta blockers, MRA, SGLT2 inhibitors, and you have to treat the volume load with diuretics. Now we have, other than fusimide, you have tosimide, and another acetosamide is also there. So if the patient has LBB and QRS is widening, there's a place for CRT, but the now trend is towards left his bundle branch pacing and left bundle pacing is but still have to come to the guidelines as well. If the patient is having, but if the still patient is not LB, but the patient QRS is more than 130, HS is more than 120, there's a still pace of CRT, but the cause of recommendation is less. And if the patient's EF is less than 35, you can consider ICD after optimal medical therapy for 3 months, and the patient was and ischemic it's class 1A recommendation. In patient of AF, you can do anticoagulation, and if you can start digoxin as well. There's a recent meta-analysis showing the digoxin is helpful if the patient is AF, but if the patient is not AF but still having reduced ejection fraction, it is probably is harmful. So better not, you should not use digoxin if the patient is not AF. And if the patient is having coronary heart disease, you can have, usually what the cardiomyopathy definition says no ischemic heart disease, but sometimes we may diagnose cardiomyopathy, but there can be ischemic element also. In that case, you can do a revascularizing as well. More trials favor CABG than PCI. And if the patient is iron deficient, you can do IV iron. And there's AS, you can treat with aortic valve replacement. There's MR, you can ideal to mitral valve repair, trans H2H mitral valve repair, iodine, hydrolyzine, and things like that also there. And end stage will be the cardiac transplantation. And there are things like exercise rehabilitation and multidisciplinary approach is always helpful. This is also important because we should try to treat, so in this trial, the SGLT2 inhibitors are not there, this was meta-analysis done. So now we have 4 drugs, so you have to start all these 4 drugs within a short period of time. So if we can start ideally within, we can start the low dose in the hospital stay and add-on treat going within very short period of time, the maximum tolerable dose. So then I will move to the case. So this patient is 35 years, P2C1, post-op LSCS day 2, developed dry cough, dyspnea and orthopnea. There's no past medical history, and there's father and family history of heart failure as well. So what are the differential diagnosis? So examination, JMP level, blood pressure lower side, tachycardic, sinus tachycardia. There's evidence of mitral regurgitation with pulmonary congestion. So this patient has neutrophil leukocytosis, slightly elevated CRP. Tropi is slightly elevated, and there's chest excision, cardiomegaly fluid effusion. And if you have facilities, you can do a procalcitonin, which is found in normal. Because pneumonia, patient with procalcitonin normal is very unlikely to have a bacterial pneumonia. You should ideally you should do NT-proBNP level, which is high. So this patient obviously in heart failure, infective etiology is a bit unlikely. There's inflammation is going on. There's possible MR. And patient is having pulmonary congestion. So in the echo showing EF of 25% with apical hypokinesia at moderate MR with pericardial, small pericardial effusion. So what are the treatment options? You reduce the congestion with diuretics. Ideally, you should try non-catecholamine like I will use amendment because we may suspect Takotsubo cardiomyopathy as well, which is better not to give. Should not give catecholamine based iron drops. After that, if it's not there, you can with dobutamine or dopamine. You should have subcardiac enoxaparin due to high risk of pulmonary DVT and pulmonary embolism, and bromocriptine because you are suspecting peripartum cardiomyopathy, and gradual introduction of standard heart failure treatment and continuation. So, what are the differential diagnosis? Shortness of breath in peripartum. It can be pulmonary embolism. First thing we come is pulmonary embolism. It can be acute coronary syndrome, lower respiratory infection, myocarditis, Takotsubo cardiomyopathy, peripartum, and previous undiagnosed cardiomyopathy, and which can be even previous undiagnosed valvular heart disease post manifestation in the pregnancy, and amniotic fluid embolism as well. So what is peripartum cardiomyopathy? Now they usually are EF less than 45. It was toward the late time of the pregnancy and following months of pregnancy. So they don't define the exact months, but usually even they can develop after 6 months, like up to 1 year, they can develop this peripartum cardiomyopathy. And other thing is it's a diagnosis of exclusion, so there should be no other cause of heart failure should be found. So what are the pathophysiology? They can have cytokine-mediated inflammation, oxidative unbalance, because placenta is a good antioxidant, having antioxidant properties. So there is unbalanced oxidative stress, and prolactin has shown to be in pathogenesis and abnormal immune response to pregnancy, and because they have found some autoantibodies and some subclinical infections which has been reactivated during pregnancy because it's an immunocompromised state. So all these factors contribute. So if the patient is already diagnosed of peripartum cardiomyopathy, you should have preconception echo and end of first time like this. I will skip. So what are the during pregnancy? What are the drugs we can give? You can give beta blockers, loop diuretics, hydroxyzine IST, and digoxin, heparin, but you should not give ACE inhibitor, ARV, aldosterone receptor antagonist. So are you ready? So these are the drugs which can be given. Safe drugs are in the green color. So you can give loop diet beta blockers, which can cause IUGR and fetal bradycardia, but usually they are, because the benefit is more than the risk, so you can safely you can give it monitoring. So these drugs which you should not give in the pregnancy, but they can be safely given after pregnancy. Okay, cinnamon, spironolactone, we can be good, although it can be in the breast milk, but the amount is slight, which is less, which can cause harmful to infants. And low molecular weight, and you can give offering after pregnancy or in the second trimester. Or you can give offering if the offering dose is 5 milligram, you need the first trimester. Other condition like A4, things like. What are treatment options? You can give bromocriptine, which is a class 2B from ESC guideline. So there's a risk of hypercoagulability with warfarin, so you should always try anticoagulation with warfarin, and you should consider it if the EF is less than 35. So there are what this called this board concept. There's bromocriptine and oral heart failure therapies, anticoagulant, vasoactive agents, and diuretics. And breastfeeding should be actually discouraged because it will increase the prolactin and this will increase the cardiac stress to the heart. So if the EF is less than 30 or below, you should actually discourage the breastfeeding as well. Right. These are the experimental therapies, like there are some vasorelaxins like things are also in the. So if there's no contraindication, you can ideally try vaginal delivery, and if there's an obstetric indication, you can do LSCs. So what about the future pregnancies? So if the patient recovered, they can have low risk of for recurrence, and you can advise pregnancy with but close monitoring. But if this not recovered, you should have a discussion with the patient and better discourage the pregnancy. But it will depend. You have based it on the case by case. If the patient was the first child passed away or something like that, you have to consider. But if this EF is very low, there's a very high chance of recovery and very high chance of maternal death. But you can continue the guideline directed medical therapy unless unless it is contraindicated in the pregnancy. For example, we can continue beta blockers. So right, we'll go for the restrictive cardiomyopathy, and so this is mainly there's impaired ventricular filling is there, and usually systolic function is normal in the first initial phase. So there are various types of restrictive cardiomyopathy which can have restrictive type infiltrative or non-infiltrative. So I will move to the case presentation. So this is a 61 years old patient, present with shortness of breath for 1 month, NIH class 2 to 3, and there's low limb swelling and inflammatory type diarrhea for the urine. And the patient have diabetes and hypertension. So what are your decisions? So what do you think? Okay. So this patient also have macroplasia and ecchymotic patches and pitting edema. So more likely this is amyloidosis. So this patient have elevated JMP and pleural effusion, and the fundi normal. So diabetic is causing proteinuria is a bit unlikely in this case. And urine protein excretion is high. And there's pleural effusion, and there's a pericardial effusion is there, and biatrial dilatation with, I would say there's increased intraventricular septal thickness. But compared, this is not a, what you say is not a hypertrophic cardiomyopathy, which is all the clinical picture is all favoring. It's like an infiltrative cardiomyopathy than hypertrophic cardiomyopathy. This patient having low ejection fraction, there is severe biatrial dilatation and increased IVS. So I'm going to skip this echocardiography findings, and the GLS global efficacy is a good method. We can diagnose without have a good sensitivity, around 92%, which we don't have facilities like cardiac MRI. This they have just cherry on the top appearance. So this is a postmortem finding showing gross cardiomegaly. So if you do a concordate staining, you can have the salmon pink patches, and there is underpolarized. You can see this apple green amyloid deposits. Ideally, you should do this tissue type by mass spectrometry or immunohistochemistry. So how do you diagnose cardiac amyloidosis? You take a history and examination. Ideally, you have to do the cardiac MRI, and you have to do this actual 3 investigation: serum kappa and lambda free light chain assay with immunosuccession. Not mere serum protein electrophoresis is not enough, and you have to do a serum floating electrophoresis with immunofixation during ideal 24-hour urine floating electrophoresis with immunofixation, and serum free kappa and lambda light chain assays. And after that, if these all are negative, if these positive, is more likely AL amyloidosis, and you have to go for a histology. You can go for a rectal biopsy, or if it is ideally facilitated, you have to put a targeted organ biopsy like renal biopsy or cardiac biopsy, endomyocardial biopsy. So if it is everything is negative, it's unlikely to be cardiac amyloidosis. But if it is AL amyloidosis excluded, you can do this technique 99 pyrophosphate scan, which will favor ATTR amyloidosis. If it is favoring ATTR amyloidosis, you have to do genetic studies as well. And if you are doing endomyocardial biopsy, you have this tissue type with mass spectrometry. So these are the criteria and echo I'm going to skip. Yeah. So there are newer types of drugs which target like TTR stabilizer tafamidis, which are being not in Sri Lanka but in other countries, and various other like for ATTR amyloidosis mainly. Right. So you'll move for the third case. So this is a 56 years old patient with type 2 diabetes mellitus for 12 years, hypertension, dyslipidemia, shortness of breath for class 2 to 3 with no chest pain or ischemic heart disease. Patient has higher BMI and high waist circumference with hypertension with normal heart rate. And this patient LDL is 210, triglyceride is elevated, their sodium ACR is higher, macroproteinuria is there, there's creatine normal with high HbA1c level. So this patient electrolytes are basically normal with high ACD, ALT and low platelet count and ECG unremarkable. And 2D code showing is normal EF, not normal, slightly less EF with grade 2 diastolic dysfunction with LVH with no evidence of pulmonary embolism or valve diseases. So if you do we do a coronary angiogram showing mild coronary heart disease only. So what is this condition? So this patient was having HFpEF with metabolic syndrome, like which was discussed in the previous lecture as well. And this patient was on amlodipine, metformin, and glycoside maximum dose. So this is like more like a diabetic cardiomyopathy, which is characterized by structural remodeling with cardiac hypertrophy and fibrosis. This is actually having this both type of direct cardiomyopathy, restrictive cardiomyopathy, like both like combination phenotype. So they have early onset diastolic dysfunction followed by late onset systolic dysfunction. So what are the pathophysiology? They can have hyperglycemia, this non-nitrosamine glycation of various amino acids. Protein can give rise to this especially this O-GLACNAC product, give rise to various calmodulin kinases and mitochondrial bodies. They interact with these proteins and they can cause this pathogenesis. And there's oxidative stress with increased reactive oxygen species, reduced antioxidant properties. And there's inflammation, autonomic dysfunction, which give rise to myocardial fibrosis and autonomic dysfunction. Resting tachycardia, they can have myocardial altered myocardial metabolism, mitochondrial energetics will be impaired, and there is suboptimal use of glucose and fat. And there is cardiac remodeling as well. Ideally, it's not fit to the cardiac perfusion abnormalities. You should not have macrovascular disease like coronary disease in diabetic cardiomyopathy, but they can coexist. So usually they can have these various adverse glycation products, hyperglycemia, lipotoxicity, glucose toxicity, and this will have oxidative stress and later due to cardiac fibrosis, which cause impaired relaxation and later systolic dysfunction as well. So what are the pathophysiology? So you can have this oxidative stress, inflammation, autonomic dysfunction, systolic and systolic dysfunction later. They can have cardiac cell apoptosis, and even they can have hypertension and microvascular ischemia as well. So what can be the treatment we can give? So cardiac wise, you can give ARNI, that is beneficial because EF less than 57, especially females, this is beneficial effect is there, and ACE inhibitors or ARBs, SGLT1 or 2 inhibitors, empagliflozin, and SGLT2 inhibitors like sotagliflozin, also proven in HFpEF also. Then you can give to this patient also an LDL of 210, it's a very high risk. You can have to give high intensity statins, and usually what we expect is high intensity less than 50% reduction. So you may have to combine acetylmide as well, but we do not have PCSK9 at government sector. It's very difficult to get also. And patient have beneficial effect of aspirin from a trial, and patient there's a microvascular ischemia, so you can mitochondrial oxidative damage is also there, so you can have this tranloxine or trimethylene also. So blood pressure reduction ideally 130, but you can, if your patient is asthma, you can target lesser than that. LDL target should be 55 because this patient having features of target organ damage, and HbA1c rate of 6.5 or less, you have to do TSH, and ideally you should do a GLS because subclinical heart failure LV dysfunction can be only diagnosed with GLS. So diet and exercise, this score we can put in the diabetes advanced and dial models, telemedicine health promotion assets. So how to diagnose, how to treat the diabetes? So you can do a tirzepatide, dual GLP-1 GM agonist, so you can have GLP-2 receptor agonist like semaglutide, dulaglutide, liraglutide. And linagliptin is the preferred drug because patient is having proteinuria, so an insulin analogs, bariatric surgeries. Ideal patient will have beneficial effect even if the patient is HbA1c normal. You have to prevent the blood sugar fluctuations with CGM. Bionic pancreas will be handy. But another thing is you have to consider other screening like macro and micro and OH6 and diabetic food. Since this patient was having high ALT, AST with low platelet, you have to ideally have a NAFLD or MAFLD screening with investigation treatment and possibly fibroscan as well. Right. So why do I check this patient LDL should be less than 55? It's because patient has target organ damage. Or if the patient severe target organ damage can be. I'm going to skip this. And but mind you, the Indian guidelines says the very high risk group, the LDL should be less than 30 as well. Right. So I would like to thank my trainers, Dr. Subhashini Jayavikram, and all the consultant cardiologists and teaching hospital Kandy, and my previous trainer, Dr. W.J. Skuratne as well. And there are other things like I would like to discuss, like Takotsubo cardiomyopathy and ARVC, because of this topic is vast. I did not touch those areas. Thank you very much.
Thank you. This one question, and on clinical examination and following before you diagnose by cardiomyopathy, do you routinely subject them to coronary angiograms if the is less than, let's say, 50 or
if the patient is like very low risk of ischemic heart is like around 20, and very strong family history of cardiomyopathy, we don't do. But usually, if the patients, our patients are mostly like middle-aged patients, like 30s, 40s, and they will usually have diabetes also. So in that case, we usually do because we have to can have dial cardiomyopathy, they can have ischemic cardiomyopathy as well because they have because of this obesity and other metabolic risk factors. So usually, routinely we do actually. And what you have found is when there is no low clinical suspicion, angiograms are almost completely normal. What we can do is after getting the angio, we can actually omit the unnecessary drugs like especially statins. You can omit because it is not actually harmful for cardiac function. So you can actually omit safely. But other drugs like beta blockers, ACE inhibitors, ARBs, spironolactone, you have to see you have to continue definitely, irrespective of etiology. Yeah. Because we do not have, we have CT coronary angiogram as well. Usually we do have a good invasive angiogram because our complication rate is so low. We usually do radial approach, but if the facilities are available with the low risk factor, like less younger patient, CT coronary angiogram is also a good option.
Thank you, Nira, for that excellent lecture. Any other questions from? From the virtual audience, how to differentiate sarcoid versus hemochromatosis versus amyloid in cardiomyopathy in 2D echo?
2D echo actually is a bit difficult. Amyloidosis, there are specific factors are there, like amyloidosis, you can have this as I told earlier, you can have GLS. You can do sarcoidosis. There are no specific patterns as I know from GLS. But what you can do is, if you are suspecting cardiac amyloidosis, sarcoidosis, you have to go endomyocardial biopsy because their specific treatment is there. That is the thing you have to do. So echo, it's a bit difficult, but hemochromatosis also we had to look at the whole clinical picture as well. You have to do other supportive investigation, transferring saturations, things like that, and you have to do and usually they have restrictive cardiomyopathy type, and usually they do not have the specific GLS pattern, but amyloidosis does have. But you can go ahead with cardiac amyloidosis. They can diagnose it. The question mark for echo, it's difficult to diagnose, but amyloidosis, of course, can.
Okay, thank you, Niranga, Dr. Niranga Samarathanga, for your presentation. And I would like to give you a certificate of appreciation and participation.